worries. I'll send the slides around. I'm happy if you want to distribute them because I've got some links on there as well for resources and that sort of
Thank you.
People ones. So, but yeah, you're welcome to record.
I saw there was a message from Moira this morning too. Said she'll hopefully join us, which that'll be the first time. She said Zoom willing. So I know she's not very technical savvy, so I don't know if she's at work or if she's at home. We'll see if she manages to sign in.
I didn't cross paths with her today at work, but she's usually there on a Wednesday.
I know there was one other new question, which while we're waiting,
you can see, Kristen, you can see the Monty. He's waiting for Guy to arrive.
Yes, the dog in the background. Yes.
I love that all dogs in the world somehow manage to find the perfect couch position to look out the window on the back of the couch.
Yep. We know when anybody arrives or anything, or anybody dares to walk past the house, not happy. So. Yeah. We're not really sure how many will come in. We've had a lot of ladies here show interest. So, yeah.
Yeah, no worries. I'm happy to wait a few more minutes if you'd like, whatever you want.
I'm just testing the chat feature. There's one other question that came in just in the last few days. Yeah. She said Alison said she'll probably join us. She's not on yet. But I know there was a few of the newer ladies on. I put it on and we have a private Facebook group. So I made a public event, but I only put the link in the private group. So a few of the ladies today were sort of saying, yeah, I set an alarm to try and remember today. Or that was you, Kerry, over it, wasn't it?
That was me.
A few other ladies every month, they sort of say, I forgot. And I'm like, set yourself an alarm, set yourself a reminder.
Yeah.
So hopefully some of the new ladies will join in.
Maria, have you got a video connected to your computer? And you're on mute.
I think Maria's one of the new ladies, isn't she?
Yeah.
Sorry, were you talking to me?
No, to Maria, who's blacked out. She's
on okay.
A video.
Yeah, she's unmuted. She's
okay. She's
okay. Can you hear me now?
Yes, I can hear you now. Yep.
Oh, okay. Hello, everyone.
Hi, Maria.
Hi, Maria.
Just checking. So everything's working for you? You can hear everyone?
Yes, I can hear. Yeah.
Good. Happy Pinktober.
Yeah. Good colour shirt, Kristen. Perfect.
I thought for today, the lipstick's a bit bright, but yeah, I thought I'd better put on the pink shirt and the pink thing. I've got a new camera, so I was even playing with pink backgrounds too. I didn't know how far to take it.
Yeah.
Yeah, do that.
If I can remember how. Pink buns or support group? Oh, wrong one.
Oh, that's nice.
No. Where is it? Settings. Oh, I'm still learning. Choose virtual background. There we go.
Yeah, you've just got it. Yep. That's a good one.
Great. That's so good.
Or my son was playing. So, and of course we know it's Pink Bun Day tomorrow, everyone. Got to go and buy pink buns.
Oh, is it? Oh, good.
Yep. And you can send virtual pink buns. So if you don't want to eat a pink bun, you can send a virtual one and make a donation for a 6-pack. $7 for every 6-pack. So it was someone's birthday yesterday, so I played with it. So I was like, oh, what a perfect way to send to a pink sister a donation to Breast Cancer Network Australia. And some pink buns. So yeah, I was playing.
Yeah, you could do so much. We've had it at work where we've had team meetings and all of a sudden somebody's got the Flintstones behind them or Star Trek. Yeah, a lot of fun.
Yeah.
Yeah, well, I
Like
just
the-
got new computer, new video camera, so I'm just still the last few days it's just been driving me bonkers trying to set up a copy of files across, and yeah, it's really hard to get used to.
It is. That's why we had kids.
Yes,
So they can teach us things like that.
Yep.
yes. And Josh is doing uni from home, so I think he's on semester break or maybe back at uni. So yeah, my 26-year-old and my 22-year-old, they I don't know what I'd do without them.
Ah, same. When we first went online, because I'm doing the medical reception course at TAFE, and we started going online just before Easter school holidays.
Mhm.
And I was trying to do it from because my husband's an architect and he has 2 Macs, and I thought, I'll just use one of those. And I just couldn't do it. And I had a bit of a dummy spit one day and I said, that's it, I'm going to buy a laptop. And then I brought it home. Well, I actually took Harrison shopping with me, who's 15 and loves gaming. So I've got this awesome gaming laptop now, which glows and does all pretty things. But then he sat there and spent like 2 days setting it all up for me. So, and every time something goes wrong, he's not here tonight. I'll say, Harrison, how do I fix this? It's so good.
Oh, you don't need him tonight. You're right.
Yeah. Well, I've done a lot through TAFE.
Yeah.
I've got a big reflection on my glasses. That's better. Yeah, it's taught me a lot doing it through TAFE, just trial and error.
And like, I assume, Dr. Gina, you use Zoom and internet and stuff all the time. Is that what modern doctors have to do nowadays?
Well, yeah, we've all had to sort of transition with all of our meetings to all, because we have at least sort of, I don't know, 6 to 10 meetings a week that we now have transitioned to. We use about 3 different meeting platforms, which doesn't help. We do Zoom, and there's one within the public health system that we use, which is called Hexip, and there's so it's just switching between all of them. But I think it took us a good 2-3 months for everyone to get the hang of it, and there still are glitches, but it's actually working quite well. And I think in a weird way it would have taken a long time for us to catch up with that, because I think a lot of other industries are very used to doing those things, but in medicine we've always been very face-to-face, which is what we're used to. But it's been, I guess, good to have that option for things that's allowed for people to dial in who haven't always been able to attend. So it's had its benefits in some way, but yeah, it definitely was a learning curve as well to get the hang of it.
Yeah, just had a message from Moira. She's got, is there any issues with logging into Zoom? Trying to join, been waiting for 5 minutes. So I said, no problem, have 6 logged in. She goes, we'll log out and try again.
Sometimes
it does say participants 14, so I don't know why down the bottom. I have been getting a beep, but I haven't had any little things popping up. Oh, here, 7 people.
Accept them, Kristen.
There
Yeah.
we go. Admit.
Hey.
Hello.
Hey, Kim's on. Woohoo!
That's why it was popping up, but it wasn't popping up.
There's like a waiting room where people wait until you admit them.
Normally the message pops up the top and I click on it. I can hear this ding and I'm looking. That's why I'm looking around going, where is the message? Josh has got me set up on 2 screens. So I'm like.
Mandy. Hello.
Going.
Finally get to meet you.
Nice to meet you, Glenda.
You too. And Tennille's on. Great.
Hi. And my daughter.
Oh, you don't.
Oh, a little munchkin. Hello.
We're both
Hello.
We just got a few more coming in, so if we could just hang on for a sec.
Checking I've clicked on everyone.
Yeah, just keep an eye on that because there'll be more trying to get on.
Now it's open on the side, so hopefully.
Oh, good. Okay.
Bye.
Dings. Now I've got an option to ask to unmute if I want them. Do I want anyone to unmute or not?
Just unmute for the moment till we get everyone on.
Okay. So is Moira in that list or not?
No, she's not on yet. Kim Moira sent me a message. I can't get on. What's going on?
It took me a little bit of time as well.
Okay.
That's Mummy's nurse.
I think that's part of me learning what buttons to click.
And there's that.
Hello. Are you going to help Mum? Are you?
Oh, we got Kim. Hello.
Yeah. Hello.
Hi, Kim.
Hi, Gina.
I heard a ding ding. Okay, here's some more. I hear more iPhone from
Woohoo!
Eddie and
Hey!
Molly
Hi,
Ray.
Moira.
Yay.
Moira, you did it.
Wow, we've never had this many people. Yay.
Great. And I'm sure we'll have a few more. So, yeah, Kristen, you'll need to keep an eye on that.
Okay, yep.
So don't worry, people. I'm writing just names because we're trying to keep tab of who's coming on to the Zoom. So
I like your backdrop, Kristen.
Pink buns tomorrow. What is Pinktober? Normally we decorate the room or do some parties or something. So I'm kind of missing that. Normally we
We've got matching nail polish
oh,
Oh,
woohoo!
and our toes as well. You don't put your toes up.
they're pretty pale pink.
Yeah.
That's nicer than the black chemo nail polish.
Yeah.
So Maria Scansos and Maureen Ray, are you not doing video?
Oh,
well,
no, you
I
don't want to
mustn't
see
put
me
it
at the
on properly.
moment. I'm so exhausted.
That's fine.
That's
That's
all right.
No
No,
problem.
I mustn't have put it on properly, I think.
You'll have a button normally on the left-hand side that will have video, and you can
Okay.
click onto that.
Okay, I'm just looking for it. Is that video? I haven't come on yet, have I?
No, not yet.
I can click ask to start video, but I don't want to do that for if you don't want to be video. Yeah.
You can do it, can you, for me or not? No. I'm just trying to.
Depend which one. Maureen or Maria? Who wants it?
Maureen.
Maureen. There's a big list here now.
I'll be back in a sec.
Yep.
Maureen, there. Maureen. Someone asked to start video. There we go.
So I can start my video. Thank you. Thanks, Kristen. That's it.
There we go. It's working.
There you go.
And I know Carolyn likes to not have video. I think.
Yeah, she's just connecting to audio now.
Wow. I'll take a picture now while we're just waiting for everyone to come in. So do I have everyone's permission to take a screenshot?
Yeah.
No, don't. Did I say smile?
Or look away if you don't want to. Okay, I'll screenshot. So smile. 1, 2, 3. Smile. Okay. Screenshot.
Oh,
That's fun for the records.
Maida. What is it? Love heart.
Oh, that's cute. Gina's waiting.
Oh, Kimmy.
Yeah.
We're all here.
Yay! Hey, have you heard from Alison?
Actually, yes, I did. I heard from her today.
Going
She
okay?
said- Yeah. She said as of today, she is booked on a flight home tomorrow.
Oh, wow.
Wow.
Yeah. So fingers crossed.
That hasn't been 6 weeks, is it?
No. It's only been nearly 4. But then
Right.
she's got to isolate for 2.
Yeah.
Mm.
I would say this is Di Filmer just arrived. She's coming on with me.
Oh,
Wow. Even Di's trying on phone.
Kerry.
No.
Hello. Hello.
Or you
Gee,
just look as if you've just arrived home.
Yeah. Me.
Yeah.
I haven't long been home and just finished dinner.
I wondered, yeah, if you were home yet or just had to dash home. 7 o'clock's early, isn't it?
Can be some nights.
I just arrived home after a week away and a 7-hour drive, so I just made it.
Wow. Well done, Kerry.
Oh, that's how Di's joined in. She's decided to drive to Glenda's house.
Yeah, that's what she said. She let her in.
I thought she meant let her in as in on the phone.
So you have 2 for the price of 1 here.
Hi, Di.
I die.
Hello, Di.
Shall we?
Well, we might get started.
Yes.
Yeah, Moira, would you like to do the introducing, please?
Oh, goodness me. Well,
Your coat?
yeah, seeing as I'm in my official uniform.
Yeah.
Welcome everybody, and welcome to October being Breast Awareness Month. Tonight we've got a really, we're very privileged to have a great speaker, Dr Gina Hesselburg, who's one of our radiation oncologists, and she specialises in breast radiation. And she's very kindly offered to give up some of her time tonight to provide us with some information on radiotherapy pertaining to breast cancer. So Gina, I think you've attracted a lot of interest, and I think they're expecting big things.
A bit of pressure.
But I know that
well,
you will fulfil all their expectations, I'm sure.
Thanks, Moira. Well, thank you everyone for joining and taking some time out this evening to listen and hopefully have a chat about what radiotherapy is for breast cancer. I will share my screen and give this a whirl. It's been, I'm sure, a bizarre year for all of us with COVID, and for those going through cancer treatment, an extra tough year. So just a lot of respect and admiration for all my patients who I see this year, who've just been amazing with getting through things in what can be some really tough circumstances. Tonight, I hope to go through a little bit about the basics of what breast radiotherapy is. We got some questions through which were great to touch on, and I think are a lot of the common things that people think about and want to know about radiotherapy. So I've tried to answer those in the talk and also towards the end of the talk. But please, if there are questions,
because it's moved. Sorry.
Sorry, if there are questions that pop up, feel free to unmute and ask them, or just type them in the chat option and we can answer them as we go along.
So, Jenna, can I just get everybody, if they could, just to mute?
Sure.
Just on the, should be on the left-hand side, just to mute just while Gina's talking, and then we can unmute.
All right, so yeah, please though do ask questions along the way. Sometimes it's a pity we can't be doing this face to face, and so I don't want to feel like I'm talking to a screen the whole time. So please interact, and I'm here to answer your questions and hopefully demystify what radiation is. All right, so I'll try to cover quite a bit with the talk this evening. to go through what I guess overall breast cancer treatment can look like, then what radiotherapy is, and in particular what breast radiotherapy is, talk through what all the radiation doses and grey mean, some of the common side effects, different treatment options, getting through your treatment, how to look after yourself after treatment, where we might use radiotherapy in other situations in breast cancer, some things that are on the horizon, and in and amongst the talk, hopefully there's some links to some useful resources that you can have to refer to. So if we look at just a very broad overview of what breast cancer treatment looks like, in terms of treatment at a local level, so when as oncologists we use the word local, we're talking about treatment to where the primary cancer is, and regional where the lymph nodes are. So local treatment options for breast usually involve surgery and radiation, sometimes both, maybe just one in some circumstances. And then there are systemic therapies, systemic being treatments that go throughout the whole body and can target not only the local breast and regional node areas, but also the whole body. So things like hormone therapy, chemotherapy, and targeted therapy. Every treatment course is of course individualized, and that's often based on things such as your own health, your age, but also your, sorry about that, also your pathology. So what we actually find out once you've had your biopsy or your surgery, and it's those details that we get from that pathology report that really help guide what treatment you need. It's standard practice to discuss all cases in what we call an MDT, a multidisciplinary team meeting. And so that's a meeting where we have the pathologists, so those are the doctors that actually look at the biopsy or the surgical specimens under a microscope and give us those specific details about the features of your type of cancer. There are multiple surgeons in that meeting, medical oncologists who are the doctors that prescribe chemotherapy and targeted therapy, radiation oncologists such as myself who specialize in radiotherapy, sometimes even geneticists or trial coordinators attend those meetings too. We have, of course, our nurse coordinators and other allied health at that meeting. And it's during that meeting that we, as a team, come up with what we think the recommended treatment course should be. So I always mention, I guess, all the treatment options that you might come across, because I think especially in the breast cancer sphere, there's so much information out there, and you might read about things and think, well, why am I not having hormone therapy, or was chemotherapy not an option for me? And so there's always room to ask those questions and discuss those with your oncologist, and usually there's a reason as to why one treatment is or isn't recommended. The sequencing of your treatments may vary too. Some women might have surgery up front and then go into radiotherapy, and then may or may not have hormone therapy afterwards. Some women might have surgery, then need a course of chemotherapy and then radiotherapy with or without hormone therapy. And more recently in the past years, we've shifted to a model where we're giving upfront chemotherapy before surgery and then moving on to radiation treatment after that. And the reason for that upfront chemotherapy, which we call neoadjuvant chemotherapy, is a few different reasons. Firstly, if we think that based on that biopsy and the initial picture of what the cancer looks like, there's a potential risk for the cancer to spread beyond the breast or lymph node areas, then we want to give chemotherapy up front because of the action of it to sweep through the whole body system and mop up any potential microscopic cancer cells that might be floating around, so to prevent them from taking hold anywhere else. In some cases, it might help improve operability. So if there's a tumor and the surgeon's worried that they might not be able to completely excise it, or perhaps you might be able to shrink a tumor enough that you can go for breast conservation surgery or a lumpectomy versus a mastectomy, that might be an option where we do chemo up front. Also, giving chemotherapy helps us understand the behavior of your cancer, because we can see after you've had surgery, when we look at that specimen result with the pathologist, we can see what kind of response it's had to chemo, and that again can guide treatment options afterwards. So again, just remembering that everything's very much individualized, and no two treatment pathways will be the same. So radiotherapy, what is it? I think if you haven't known someone who's gone through radiation, haven't done it yourself or worked in the space, it's a bit of an obscure treatment that not many people are familiar with, and your face might have been similar to this meme that I found of just confusion and not quite knowing what it is. I think instinctively most of us understand what surgery is. You have a cancer, you cut it out. Chemotherapy as well is, I guess, a very well-known, understandable treatment, but radiotherapy can somewhat be a little bit more of a myth and a bit less well understood. So to break that down a little bit, if we go back down to the basics of how radiation actually works, I'll talk through the most common type of radiotherapy, which is called external beam radiotherapy or radiation therapy. There are other types of radiation such as brachytherapy. I won't go into too much detail about those because that's certainly one of the less common types of radiation we use. So with external beam radiotherapy, essentially what we're delivering is a highly targeted and focused X-ray beam. The X-ray beam comes out of a machine called a linear accelerator, or a LINAC, which is this machine in the picture here. So as a patient, and some of you who have gone through the treatment will know this well, you're lying on the bed or the treatment couch, as we call it, in the position we need you in for treatment. And this is the gantry or treatment arm, and this part of the machine moves around you and can deliver the radiation from different angles. The X-rays that come out of the LINAC or the treatment machine are really no different to the X-rays that you'd have if you had a chest X-ray or a CT scan. But the difference is that we can target them very precisely to where we need to treat, and they're slightly higher energy so that they can penetrate into the areas that need treatment. The reason that we treat from multiple different angles is so that where the beams intersect can be the highest dose, and that's the area that we need to treat, but it helps then spread the dose out around the other structures so that the normal structures in your body surrounding the area that we need to treat. So in the case of breast cancer, your lungs, your heart, your chest wall aren't getting too high a dose. On a cellular level, what radiotherapy actually does is it damages the DNA in cancer cells. And cancer cells aren't very good at being able to repair that damage, which differs to our normal cells, so our skin cells, our heart cells, our lung cells. Those cells have intact repair mechanisms, so even if they get DNA damage, they can go through cycles where they repair that damage. But cancer cells can't do that so well. So when they try to replicate, which is what the nasty buggers try to do, as they go through their replication cycle, they notice that they've got DNA damage. And because they can't repair that damage, they tell themselves, okay, abort ship, and they actually kill themselves off. And that's actually how radiotherapy and quite a few of the chemotherapy agents works, is this underlying DNA damage. With radiotherapy and breast cancer, you might be thinking or asking, well, you've had your surgery, the actual cancer that we know is there is all cut out. Often we'll talk about there being clear margins, which is one of the things we look at in that pathology report to make sure that the surgeon's got it in around the breast cancer and cut it out with enough of a marginal space around it. So it's a very valid question to therefore ask, well, why do you still need radiation to kill cancer cells in the breast if I've had surgery, if I've had lymph nodes removed, and that's all been cleared? And the reason is that there's still a risk of there being microscopic disease in the breast and possibly in the lymph node areas as well. And when we speak of the lymph node areas in radiotherapy, we talk about 3 areas in particular: under the armpit, which is the axilla, above the collarbone area, which we call the SCF, which is short for supraclavicular fossa, or a chain of lymph nodes that runs just underneath the breastbone. And unfortunately, we don't yet have any imaging or blood tests that can actually help us detect whether there is microscopic disease left. But we know, and this is historically from studies, that there's a proportion of women with varying types of breast pathology that would still have microscopic disease. We know that by giving radiotherapy to the breast and or the lymph nodes, reduces the risk of breast cancer coming back locoregionally, so in the breast or the lymph nodes, and that risk reduction is by about 2/3. So if your risk after surgery of the breast cancer coming back is 30%, radiation will reduce that to 10%. And that's just radiation on its own. Plus then you have the impact of chemotherapy and the impact of hormone therapy on bringing that number down and down, because obviously we and you want that risk of recurrence to be as close to 0 as possible. The other benefits with radiotherapy is not only related to just stopping the breast cancer coming back in the breast or the lymph nodes, but that benefit actually translates to an overall survival benefit. So that means living for longer and not dying from breast cancer down the track, and also not having breast cancer come back for more years. So it has a bigger effect than just locally. Alrighty, so moving on to a little bit about the logistics of what's involved with radiotherapy. I like to think of it in terms of 3 steps to the process. So the first step is what's called the CT simulation or planning scan. So after you've seen your radiation oncologist, who in your first consultation should take you through your history and talk through the pathology of what we found from the surgery, and then as part of that process, the reasons for recommending radiation, the next step will be to book in the CT simulation or planning scan. So usually it's about a 1-hour process, and the aim of this CT scan is to acquire the details of your anatomy and your shape, and that's what we base your radiation plan off of. It's also so important that during this CT scan, we make sure that you're in a comfortable position, because we don't want you moving around when treatment's happening, and we want you to be able to lie comfortably in a position on that bed for about 15 minutes or so. And I'm sure that those of you who've had radiotherapy will attest to the bed not being the most comfortable thing in the world. So our radiation therapists, who are technicians who deliver the radiation, will try to do as much as we can to help make that positioning comfortable for you. The other important part of our treatment is that we want to be able to set you up in the exact same position every day. Because we've based your radiation treatment off of the shape and the position that you're in at the time of the CT scan, we want to get you into the exact same position and shape for each one of your subsequent treatments. So we do a couple of things to make sure that we can do that. We mark down the exact positioning of your arms, your legs, where you're lying on the bed. We also use tiny little tattoo marks, which are shown in this photo here, which are about the size of a beauty spot. They are permanent marks that are on the sides of the chest and in the middle of the chest. And those line up to lasers in the room that help to position you in the precise coordinates on the treatment bed. For some breast cancer treatments, when we're treating the left side where the heart is, and I'll go into this in a little bit more detail later in the talk, but we do a technique called deep inspiration breath hold. And so during your CT scan, we might also practice doing that deep inspiration breath hold to see if that's a technique that can work for you. The next step after you've had your CT scan is that you'll head off home, and it's in the next few weeks, and it can be anywhere between 1 to 3 weeks, that we spend time actually planning your radiation treatment. So what my job is to actually take that CT scan and outline on your anatomy exactly where I want the radiation to be delivered. And that's based again on your pathology and on discussion with you about treating the breast and plus minus the lymph nodes. I'll also decide on what dose and fraction schedule, and I'll go through what those mean, but that's essentially deciding the overall treatment dose that we want you to have and then how many treatments that needs to be delivered in. Radiation therapists will help plan that treatment. We use computer-based planning systems, and then we review those plans together. And when I'm reviewing your plan, I'm looking at 2 things. I firstly want to make sure that the area that I want treated is well covered by the radiation dose that I've prescribed. And then I want to make sure that the doses to the normal organs and structures around that area are below safe limits. We're very, anal is the wrong word, but we're very particular with radiation oncologists about what we will and won't accept, because we know that above certain dose limits, the risk to damage to normal organs goes up. So we've got very strict criteria as to what doses we'll accept. And there's very much well-published guidelines and usually within your department protocols about what doses you accept to normal structures so that we can keep the risk of any complications down the track as low as possible. Once all that's been done, the plan goes through checks with our medical physicists. There's often checks on the machine to make sure that what we've planned is being delivered. It's a whole lot of physics and sciencey stuff that goes on. And then you'll come for your treatment. So treatment is usually delivered on a daily basis, Monday to Friday, and it takes approximately 30 minutes per day from start to finish, which includes getting changed into a gown, getting into that position on the treatment bed, that set up position, and making sure that you're in the correct position on the bed, which was usually done by taking an X-ray or a little mini CT scan. And then sometimes there's some shifts that are made before the treatment is actually delivered so that you're in that exact correct position. The actual delivery of the radiation is usually very quick, usually less than 5 minutes for the machine to move around you. And what you'll hear as a patient is the machine moving, but you don't actually see the radiation being delivered, and it's not painful for the radiation to be delivered. As part of your treatment, you'll usually be booked in to see the doctors or nurses on a weekly basis, and that allows us to check that you're going through treatment okay, that you're not developing side effects, and particularly with breast cancer treatment with radiation, we're wanting to check how the skin's progressing and manage that appropriately. Over here is a link to a video that kind of steps you through those different points of treatment and those 3 steps of simulation, planning, and treatment. It's a video that we did for, I did some of my training at Prince of Wales Hospital. So some of the things are specific to that, but it does give a good overall view of what radiation involves. So this link is there, and I'll send the slides around if anyone wants to have a look at that. Alrighty, one of the things that we do with before we treat you is to make sure that you're in the correct position. I'm not sure if you can see here, there's a sort of checkerboard picture, but what this is showing is that there was one image underneath another image, the white ones overlaid on top. And what we're looking on treatment is to make sure that this breast contour over here, where my arrow is pointing to, matches up in perfect position with where we planned. And so there'll be some shifts or moves. So you can see here that the chest wall is is not lining up nicely to there, but with a few shifts, it comes back into the correct position. And that's the precision with which we're treating you too. In terms of things to consider with your treatment, in Australia, we're fortunate to have, for the most part, good access to radiation departments across New South Wales and Australia, although still, I think in some of our rural and remote locations, it's obviously a bit more tricky for patients to get their radiation done given their need for daily treatments. But certainly there's radiotherapy accessible for all. And all radiation departments will offer breast radiotherapy. It's one of the bread and butter types of treatment that we do, that and prostate cancer radiotherapy. There's treatment at the public hospitals is always bulk billed, so there should be no out-of-pocket cost to you. There are private centres too, such as Genesis or Icon, which offer treatment, but that's usually associated with an out-of-pocket cost, and private health funds don't cover it. There are slight variations in techniques or trials on offered between different departments or some of the equipment that might be used. But I can say quite confidently that across the board in all Australian radiotherapy departments, we deliver world-class radiotherapy, and for the most part in the departments I've worked in, all the teams are lovely, the treatment's all excellent. So I think wherever you have treatment, you're in good hands for the most part. All right, so just to explain a little bit, I guess, about where we're actually treating and what things we're looking at when we're doing your planning. Sorry. So this is a CT scan from that CT simulation or planning scan, which is looking at you as if we've taken a slice like a loaf of bread. And this is looking at you with your heart in the middle, your 2 lungs, which are the black sort of semicircles, and then the breasts on either side. And over here, you can see this is the breast tissue that we're covering with that green colouring in. And then the blue is where the tumour bed was, and the orange is a margin around where that tumour bed is. So in this case, this woman's having her whole breast treated and then having a boost, so a slightly higher dose, just concentrated around the area where the tumour was. In some cases, we don't need to treat the whole breast, and in that circumstance, we call that partial breast irradiation. And that's where we're only treating where the tumour was and a small area around that. And there's a few different ways that we can deliver partial breast. One of them is brachytherapy. I'll go through that in a little bit more detail. And we can also deliver partial breast radiotherapy with external beam radiation. This isn't a standard treatment yet, and it's not always available to every patient because you have to fit into a very sort of early low risk category to be considered for partial breast radiotherapy, because we don't want to miss or undertreat the other areas of the breast that might be harboring the microscopic disease, which I mentioned at the start of the talk, I should say. Other areas that we treat with radiotherapy are the chest wall. So for women who've had mastectomy, or even if you've had mastectomy and reconstruction, treating that area of soft tissue that overlies the implant. And then the regional nodes. So those are the lymph node areas that are sitting in the armpits, so underneath this in the axilla, and then that track up into the collarbone area over there. And we'll often do those treatments in conjunction, but certainly you can just have the chest wall treated or just have your breast treated. All right, 50 Shades of Grey. You might have heard this being tossed around in your consultation or coming up in booklets or in discussion with people, what your radiation doses is and what they mean. And there's certainly a lot of variation as to what the treatment schedules are. So firstly, when we talk about grays, that's essentially the unit of measurement that we use to measure the dose in radiotherapy. So just like a milligram or a milliliter, gray is the unit of measurement for radiotherapy. We often shorten that to GY for gray. When we're delivering your radiation treatment, we want to deliver an overall total dose of treatment. But we don't deliver that all in one go. We divide it up into daily treatments. As you would know, you're coming back and forth for your treatment every day. And we often refer to those daily treatments as fractions. The reason why we actually do that is not from a cancer point of view, but it's actually to try and allow for your normal tissues, so the skin, your lungs, the other structures around the breast that are getting a small dose of radiation to heal in between. And that goes back to what I was saying at the beginning of the talk, that when radiotherapy causes that DNA damage, our normal cells, the cells in our normal skin and our lungs and our heart, they're very good at repairing. So in between each of those fractions, those normal cells repair, the cancer cells can't, and we exploit that difference, and that allows for there to be minimal damage to the normal tissue, but for there to be maximal damage to the cancer cells. There are varying dose and fraction schedules, and these have resulted from historically what's been used in studies, and then also it will depend a little bit on what each department or each radiation oncologist uses preferentially. Probably about 10 years ago, the standard treatment course for breast radiation was 25 treatments. So that was 50 gray given over 25 treatments, so 2 gray per fraction. So it's just a bit of division there. More and more, we're using what we call hypofractionated treatments, which just means slightly shorter treatment courses. And so these are delivered in 15 or 16 treatments, so around 3 weeks of treatment. And even though this looks like a smaller number of, or a lower radiation dose being delivered, 40 or 42 compared to 50, it actually equates to the same dose, or it has the same impact on the cancer cells because we're delivering a slightly higher dose per fraction. And that's based on some radiobiological modeling and calculations that we've worked that out. So those doses represent, the dose to the whole breast or the whole chest wall that we're delivering. We might at the same time deliver a boost. So that's that extra dose of radiation concentrated around where the tumor was. And that can be delivered either after you finish your 5 or 3 weeks of treatment, or it can be delivered simultaneously. So while you're having your 15 treatments, a slightly higher dose is being delivered to that area around the boost. And we call that a simultaneous integrated boost. Alrighty, so I'll move on to a little bit about radiation side effects and how we think of them. And in this box over here, I've listed some links to information resources from a site called Everq, which I'm not sure if you've accessed before, but they've got some really great patient information sheets which break down side effects and frequently asked questions. And so you'll be able to click on those links to take you to those information sheets. When we talk about radiation side effects, we think of them in terms of their time frames. So we talk about them in terms of short-term or acute side effects. So those are side effects that might happen during your treatment and last up to 3 months afterwards, sometimes up to 6 months. Subacute are side effects that may occur in the 6 months after treatment, and there are only a couple of subacute side effects with breast cancer radiotherapy. And then late side effects are radiation side effects that may occur in the months or years following radiotherapy. So I've tried to break these down into the main groups of short-term and long-term side effects, and really into what we see that are common and those that are uncommon. So the most common thing that we'll see during breast radiotherapy are skin reactions. So this can range from very mild sunburn, redness type reaction to the skin to usually towards the end of treatment, peeling away of the skin. Sometimes you might also have a rash. There could be some itchiness associated with that as well. Sometimes it can be a little bit painful, but usually we'll see you during treatment and manage those skin reactions as you go along. If you're having breast radiotherapy, sometimes the breast can feel a little bit achy or swollen. And if you're having chest wall radiotherapy, sometimes the chest can feel a little bit achy too. And that's a combination of the inflammation that's happening from the radiation and also post-surgery healing as well. The other most common side effect is probably fatigue. And fatigue is one of those side effects that very much varies between women. Some women have hardly any fatigue at all and will carry on working, looking after kids, doing what they need to do. Some women are really knocked out by radiotherapy, and it's very hard to know which women will be affected by fatigue or not. What I say to most patients is to keep up with a bit of light, gentle exercise, but to also listen to your body and to rest and have an early night if need be. Also, by the time some women get to their radiotherapy, you've already had big operations, long courses of chemotherapy. You're exhausted by even just from that, and then we put you through weeks of radiotherapy treatment. So you're well and truly done by the time you finish your radiation, and understandably, your body is feeling very fatigued. You might develop a little bit of shoulder stiffness, and that's mainly because we have you in a treatment position with your arms above your head, and lying in that position for 15-20 minutes a day can sometimes be uncomfortable, particularly as well if you've had a bit of stiffness after your surgery, which can happen when you've had lymph node surgery too. If you have any hair in your armpits or around the chest or nipple, that can fall out with radiotherapy. And sometimes if we're treating the lymph node areas that sit above the collarbone, it can be close to the throat. So you can have a very mild sore throat, but usually it shouldn't impair your eating or drinking in any way. Some of the very uncommon or rare side effects that we might see in that acute or subacute 6-month period are pericarditis. I can't say that I've ever seen a case of that. And usually if it were to happen, you would not need to come into hospital. It would be able to be managed at home. And similarly with pneumonitis, which is a lung inflammation, it feels like a bad chest infection where you'd have a cough and fever, and you would feel a bit crook with it. In this day and age, we'd be testing you for COVID, but if it's a pneumonitis, lung inflammation from radiation, again, that's usually very manageable at home with some steroids, and it only happens in about 1 to 2% of women who have radiotherapy. Some of the late side effects that we see can develop in the months or years after radiotherapy. Again, there are ones that are common and ones that are very uncommon or rare. So commonly you will notice some change to your skin on that side. Some women's skin returns almost to normal and you can hardly tell which side has had radiotherapy. But then for most women, there'll be a slight tanned area where the radiation treatment was. In this woman has had reconstruction, so her breast contour and shape is different from her other side. And she's also had radiotherapy. You can see that there's a tan sort of outline there that indicates where her radiation was. Usually, though, it's very subtle and mild. You'd still be able to wear t-shirts with low neck, and it wouldn't be a very obvious difference between the two sides. You might also notice your nipples color is different from one side to the other too. Sometimes that achiness in the breast or chest wall can persist a little bit. One of the common descriptions that some women have, which can be in the months or years after radiation, is that they don't have any pain, but occasionally you just get these twinges or sort of sharp shooting sensations that come and go in seconds, but there shouldn't be any residual ongoing pain in your breast or in your chest wall after radiotherapy. If you've had breast radiation, you might notice in the years following on from treatment that the breast that's been treated feels slightly firmer compared to the other side. It sits a little bit higher on the chest wall. There can be a very subtle contour difference. Again, it shouldn't be something that one would notice wearing a bra or a bather, but you might notice that yourself. A lot of women will jokingly ask for the other side to be done because it gives you a little bit of perkiness back. So that's a common thing that we see. When you're talking to your oncologist, they might mention that there's a risk of developing lung fibrosis. That means a little bit of scarring in the lung tissue, and I've tried to find a CT scan that shows that over there. Lung fibrosis usually doesn't translate to anything clinically, meaning that you shouldn't feel unwell with it, you shouldn't have any breathing problems. But what you can see if you were to have a CT scan, there's a little band of this white lung tissue over here, and that correlates to where the radiation beams passed and skimmed the chest wall and the lung over there. Lymphedema is another one of the risks following radiotherapy and surgery. Lymphedema refers to swelling in the arm that results from there being impaired lymphatic drainage, and that's due to treatment in the lymph node areas. The risk very much varies depending on what surgery you've had, so whether you've only had a sentinel lymph node biopsy or if you've had a full clearance of all the lymph nodes in the axilla and the armpit. And then if you've had radiotherapy to the armpit or to the other lymph node areas. The risk ranges between about 5 or 10 to 30% of that happening. So some of the more uncommon or rare side effects from radiation include heart problems, and I'll go through this in a little bit more detail, but we quote a risk of about 5 to 6%, which is a cumulative lifetime risk. That particular number comes from a study that looked at women at the 10-year mark. So that was the risk of there being heart issues. And again, the study where this number comes from was looking at women treated in a period before 2004. So we're almost going on to 20 years after that. So the radiation techniques that were used were definitely much older and not as conformal or avoiding of the heart. So the number in reality with radiation treatment today is probably much lower. I still quote that number just because I'd rather err on the side of overestimating, but I think the numbers in reality much lower. There's a small risk of a rib fracture, and that's because the side that's had radiation, where the rib cage passes underneath the breast, the ribs are slightly weakened, and so if you were to have a fall or impact on that side, that could result in a fracture. In theory, there's a risk of developing a second cancer with radiotherapy. The risk's around 1 in 1,000, and it depends again on your age and other factors, but usually for women who are younger, that risk is slightly higher. And again, that's also because it's a lifetime risk, and secondary cancers usually only come about in 7, 10, 15 years after treatment. Nerve damage is a very rare thing that would happen with radiotherapy, and that's due to the position of the nerves that track down from your neck through your collarbone to supply your arm. Again, I can't say that I've seen nerve damage from breast radiotherapy. We sometimes see it when we're treating head and neck cancers, which we treat to a much higher dose, and in that case, there is a higher risk of that happening. If we've delivered radiotherapy after you've had a breast reconstruction, so with an implant in or even with an expander, it can sometimes result in complications down the track to the reconstructed breast too. All right, so some practicalities on getting through treatment. Again, if you've had treatment, you probably are familiar with some of these things, and if you're about to have treatment, then hopefully this helps give you a little bit of an idea of things that you can do. So one of the main things we focus on when you're going through your treatment is your skincare. Usually we'll start off with just recommending keeping the skin nice and moisturized with basic non-perfumed moisturizers such as Sorbolene or QV cream. And then if needed, as treatment goes on and as we review you and our nurses review you, we'll recommend potentially other creams that will help if you've got a little bit of skin irritation, dermatitis or breakdown. You might have heard of Solucite gel or Flamazine, which is a silver sulfur-based cream, hydrocortisone, which is a very mild steroid cream that we use if you've developed a bit of itch. In some cases, particularly if you've had a mastectomy and we're giving chest wall radiotherapy, we might use a very thin plastic-like dressing called Mepitil, which is shown in the photo here, or a gel called Strata XRT, which helps provide a protective skin barrier. We might also do saline soaks, which is essentially salt water that's cooled down and with a cloth soaked in the salt water and then placed over the skin. And again, that provides both hydration and a bit of relief from the treatment. And these are things that your treating team should be able to guide you through and what to do at different points in the game. In terms of exercising during your treatment, I think, again, it's a good thing to maintain a little bit of gentle or mild exercise, and that could be walking for 10 minutes a day. Again, it's important to listen to what feels right for you. In some circumstances, you wouldn't want to be getting too sweaty, because if you've got Mepitil or if you've having treatment, it can be uncomfortable if your breasts are rubbing against the skin underneath or against your arm if you're exercising, but it's still okay to do some gentle exercise. A lot of women ask about whether they can continue to work, and again, this is on an individual basis. If you feel up for it, certainly you can, but again, some women might feel very tired. They might be having side effects, either lagging from their previous treatments or during radiation, and might just make work not feasible. And any one of your treating doctors will be able to provide you with certificates to support time off work if you need. During treatment, you can eat anything, as we would always say, a healthy, balanced diet, but there's certainly no foods that we'd say are off limits. The only thing we do recommend is to stop any sort of high dose multivitamin tablets that you might be taking. This is because radiation works, as I mentioned, by causing that DNA damage, and that DNA damage is actually fixed or sort of made permanent by there being free radicals in the system. And a lot of the multivitamins mop up free radicals, and so in theory they sort of have opposing effects. I don't think that's been borne out in any research to show that it has any major impact, but for a few weeks, stopping multivitamin treatments is usually a feasible thing to do. Here's another link to a really good document that's on this website, Everq, about skin changes and things to look out for, things to avoid. And that's it's just a 2-page brochure, but I think it's a very useful one. Following on from radiotherapy, so not only just in the few months afterwards, but even in the years down the track, these are some things to I think keep in mind and to make sure you keep on top of going forward. In terms of your skin and the area that's been treated, I would always say to continue to moisturize, certainly not as religiously as you need to during treatment, but the skin can always be a little bit dry on the one side compared to the other. The other thing that we would always say is to avoid direct sun exposure. So unfortunately, not too much topless tanning to be had after radiotherapy, but then that's again because that skin's been exposed to radiation and we wouldn't want it would be a little bit more prone to burning. So we'd recommend the usual covering up using sunscreen. The other important thing, particularly in women who've had left-sided breast cancers treated, and that's again because of the proximity of the heart to that area, is to optimize your heart health. And that includes making sure things like your blood pressure, diabetes, cholesterol are under control, maintaining a good weight, staying active, stopping smoking if you are a smoker, avoiding excess alcohol intake, maintaining a healthy diet, and checking up regularly with your GP, and if need be, having a cardiologist review as well. It's important to optimize your bone health, not necessarily directly from radiotherapy, but if a lot of women will be on some form of hormone therapy, or if you've had chemotherapy that's put you into early menopause, essentially a lack of estrogen in the body has a detrimental effect to our bones. And while it's important in women who have estrogen or hormone positive breast cancers to not have too much estrogen floating around, which is why we start hormone therapy, the downside of that is that it can impact your bone strength and cause osteoporosis. So again, we'd recommend having a good diet, and if need be, supplementing that with calcium and vitamin D. Weight-bearing exercises are the type of exercise that have been shown to actually improve bone strength. Getting regular bone densities checked if need be, and if there is osteoporosis, then considering medications. Regular breast checks, I think, is a given, and that will be part of your follow-up, and that includes both your doctors examining you, but also regular mammograms and ultrasounds, which will be done on usually a yearly basis rather than a 2-yearly basis after you've had a diagnosis. If you do or have developed lymphedema from your treatment, then staying on top of that too, to minimize it and make sure that there are no complications from the lymphedema are important. So that can be anything from making sure you're attending regular massage or physiotherapy, wearing compression stockings when need be, particularly when there's sort of extremes of weather, very hot weather, maintaining a healthy weight, and also optimizing skincare, minimizing any risk of infection in that arm and things like that. Alrighty, so just popped in a little slide, and I think this came up as a question somebody had asked in the chat about other areas where radiotherapy can be used for treatment in breast cancer and how effective those treatments are. And we certainly do use radiation beyond just treating the breast or chest wall and lymph nodes. So radiation is commonly used in women who have breast cancer that's spread into their bones, bone metastases. In the spinal cord, that might be used if you're having pain, back pain, but also if we're worried that the cancer might be getting close to the nerves or spinal cord in that area. And radiation is a very effective treatment at shrinking those bone metastases down and helping with pain and helping to control things locally. Usually we quote a rate of about 80 to 90% pain control with radiotherapy, and that can be in really any bone of the body that might have cancer there. Here, this is an image from a woman who had cancer that spread to her collarbone, which is highlighted here in this sort of pink area, and then also to the shoulder. We also use radiotherapy to treat brain metastases, so breast cancer that may have spread to the brain. Most commonly and more commonly today, we doing what's called stereotactic radiotherapy, which is a very highly targeted focused radiotherapy treatment, which is this treatment picture indicated on the left over here. And so the red or the yellow area is the high dose region of the radiotherapy, and blue is the low dose. So we're able to concentrate the radiation to where the cancer is sitting in the brain. And by doing that, we limit the side effects of when you treat the whole brain, which can include things like memory impairment and tiredness. In some circumstances, though, we do need to treat the whole brain, and in that case, radiation can be used too. Usually the length of these treatment courses is much shorter. The number of fractions of treatments, usually in the order of 3, 5, or 10 treatments roughly. Sometimes we can even do a single treatment if need be, and certainly that can help with things like pain quite rapidly. We can also use radiotherapy using a similar, that stereotactic technique, that very targeted focused radiation technique to treat breast cancer that's spread to the liver or lungs. In studies that have looked at this treatment, it's been shown that it can control things in about 80% of cases. So, and that's at the 2-year mark for those studies. So they have good rates of controlling things. And usually these treatments are done in conjunction with systemic therapy. So you might be on chemotherapy, hormone therapy, targeted therapy, and radiation is used in between to help just control certain areas in that setting. What things are on the horizon or things to look forward to? Certainly there's a paradigm shift looking to less is more. So as much as we can, we're wanting to not treat as much of the breast if we can avoid it. And that goes back to that partial breast treatment technique. And in these images over here, I've demonstrated one of the partial breast techniques, which is called breast brachytherapy. In this technique, a number of catheters are inserted through the breast. It's done under general anesthetic. And after you wake up from surgery, what you'll notice is just a few little small plastic buttons that are sitting on the skin surface. And then that allows for us to deliver radiation internally. You can see over here, this is a CT scan that shows the white catheters, or those white dots coming through. And it allows us to very much localize radiation to just where the cancer was sitting initially, and it avoids radiation to the lung and to the heart underneath. At St George Hospital, we've been running a breast brachytherapy trial now for over 5 years, I think. And so it's something that we now are well versed in. And certainly if you've got a breast cancer that is low risk and an early breast cancer, it's something that we'd consider for you. There's quite a strict criteria though, so it might not always be offered as part of your consult, but if it is available, and again, when we're sitting in that multidisciplinary treatment, we flag if we think somebody would be suitable for the trial, then usually it's offered. The other things that are coming out in recent research that's been published is that instead of delivering treatment in what we used to deliver in 25 treatments, and then I said now more commonly it's between 15 to 16 treatments, we're looking at whether we can even reduce that further. And there's evidence to support, and I think this will come into play in the years to come, that we can probably do the treatment in only 5 treatments. So reduce your treatment down to 1 week. Again, that's not going to be suitable for all women and all types of breast cancers, but that's something that will be coming out in the future too. At some sites, we're looking at doing tattooless, sorry, I spelled tattoo incorrectly there, tattooless breast radiotherapy. And so that's instead of using the little tattoo marks on the skin, we don't use tattoos, and we use other surface markers to make sure that you're in the correct position. And that's been enabled by a new technology that can accurately map your body surface. There's ongoing research into looking at neoadjuvant treatments, so treatments before you actually get to the surgery. And this is more the medical oncology space, but certainly there's ongoing development in terms of targeted and immune therapies in breast cancer, and more the landscape of breast cancer treatment is changing and evolving, and things that were 10, 15 years ago, considered untreatable, now we're treating women for many years down the track. So there's been amazing progress in that space. I've hopefully covered some of the questions in my talk so far. There were some that I've just listed now on their own to answer as we go along. And then when I've finished these, I'll open up the floor to any new questions that might have come up during the talk. So one of the questions was, how effective is radiotherapy on its own? And the answer is it's very effective in its own right. Radiation is an extra dose of treatment to the breast and to the lymph nodes. So it's focusing and I guess giving an extra whack of treatment to that microscopic disease in the breast and lymph node area. Some women might not have chemo or hormone therapy at all. And so it might just be surgery and radiotherapy for some women. And in that case, treatment's absolutely effective with those 2 modalities. You would never use radiation entirely on its own for breast cancer. It's usually always done in conjunction with surgery. There are a few exceptions to that though, if if in some women who have very advanced breast cancers, they might not be suitable for surgery, particularly if they've already spread up front. And in that case, we might use radiotherapy to the breast to help with pain or bleeding from the breast cancer itself. But usually it's done at least in conjunction with surgery. Like I mentioned before, it not only decreases the chance of breast cancer coming back in the breast or the lymph nodes, but also improves your overall survival and recurrence risk. And it drops the risk of recurring locally by about 2/3. A few of the questions covered the area of cardiac and heart health, and that seems to be, I think, something that certainly weighs on women's minds with breast radiotherapy treatment. So one of the questions was, how is the heart protected? There are a number of different ways and techniques that we use to try and minimize the dose to the heart. So one of these is a prone breast irradiation technique. So the word prone essentially means lying on your stomach. And in this technique, we have you lying on a board where there's a hole cut out for the side of the breast that we want to treat, and the breast falls through into that hole. So instead of, as you can see in this picture in A, instead of lying on your back and the breast radiotherapy being delivered and crossing through the heart, with the breast falling forward, we're actually able to deliver the radiation to the breast tissue, and the heart, due to that position, is back and out of the way. Not all centres will do prone breast irradiation, but we do that at St George Hospital. Again, you have to have the right anatomy, so it's usually suitable in women who have larger, more pendulous breasts, and you also have to be able to lie comfortably on your stomach with your arms above your head, which is not always comfortable for everyone. The other technique that we use, which is probably more common at more centres, is deep inspiration breath hold. So that's the DIBH acronym. This is an image here showing radiation beam passing through the chest wall. And you can see that the heart sits quite close on the left side, just underneath the chest wall there. As we take a deep breath in though, our lungs expand and actually push the heart back out of the way, and that pushes it out of the way of the radiotherapy beam. This link here I found was quite a nice little sort of animated video of how that actually happens. So you can click on that to have a look if you're interested. Again, not all women will be able to tolerate that technique, and in some women it actually doesn't always make a huge difference, because like with our breasts, they come in all shapes and sizes. Our chest wall and our heart and our anatomy is all so varied, and so sometimes some women's hearts are far away on their own. Some women find that deep breathing technique quite a difficult one to do, and there's a lot of other things that we have up our sleeve that can help us shape the beam around where we need to treat. On the left here are different radiation techniques that we use, and these are the kind of things that we're doing when we're doing your planning, so that step after you've had your CT scan and before you start your treatment. And you can see over here there's a technique where we're just aiming the two radiation beams at the breast from either side of the breast. And these are slightly more advanced radiation techniques where we use a few other smaller beams to try and shape that radiation dose. And if you look closely, I don't know if it projects so well, but you can see over here there's a bit of this blue radiation dose that's coming into the lungs, whereas with some of these other techniques we can pull that right back to shape around the chest wall. So there's a lot of things that we have to try and reduce that dose going to the heart. Some of the other questions that you had around heart health were, what are the risks and are they higher if you're of a younger age? So again, there's that 5 to 6% risk that was found at 10 years. And that's a risk of damage to the vessels, the valves, or the conducting system of the heart. If you're of a younger age, there is, in theory, more time to develop some of those complications. And like we've discussed, there's lots of things we can do to minimize your risk of developing issues by optimizing your heart health. Doing excessive cardio exercise from a radiation point of view shouldn't impact things. Certainly maintaining good cardiovascular health is important. Obviously going to extremes can never be good, and you hear of those crazy stories of, you know, super fit athletes having heart attacks from pushing themselves. So I wouldn't recommend going that far, but certainly maintaining and doing cardiovascular exercise is important, and doing everything in moderation. One woman asked if having less treatment days per week, so 4 or 5 days, resulted in less immediate skin reaction. And you might notice that when you've had your treatment, there's been a down day for varying reasons. The machines are serviced on usually a fortnightly basis to just be recalibrated. So you might have a day off on those weeks, or if there's public holidays. Certainly there's no harm in missing a day or two in that 5-day period. And it does potentially give some more time for your normal skin cells to rejuvenate. So that's may be something that you noticed with that less immediate skin reaction. Some women may have had bolus as part of their treatments, which is a specific funny radiation thing that we use. This is a picture of what it is. It's essentially a thick jelly-like material that we put over your chest wall. And what bolus does, it acts almost as a second skin layer, and it helps bring the radiation dose up to the skin and the chest wall. Particularly in women who've had a mastectomy, there can be a very thin layer between your chest rib cage and then the skin, and a small layer of soft tissue in between. And that can make it quite difficult to deliver radiotherapy. So bolus helps to add this sort of second artificial skin layer, and so it brings the radiation dose up to where we need. So I think that was all from me from my talk, but I'd like to open up the floor, and I can stop sharing in a second just to see if there's any questions. Like Kristen said, it's Pinktober, so I love this little pink that I saw. Get those puppies checked, which I'm sure you guys are all very good at advocating that for yourselves and your friends and family. All right, so I think I'm just going to stop sharing, and I can see a couple of things that have come up in the chat. And also, if you've got any questions to ask, unmute. So Mel, you asked, how long after finishing radiation do we need to be extra careful in the sun? So it usually takes about, what you'll notice with your radiotherapy treatment when you finish, your skin reaction will still be there, and possibly even get a little bit worse for the first 10 to 14 days after treatment. But then things should turn a corner, and they should get better quite quickly. And by about the 4 to 6 week mark, should be getting back to normal. Sometimes it can take up to 2 or 3 months. So I'd certainly say for a good 3 months after radiation, just to be careful. Like I said, I wouldn't ever fully expose the area to sun, but certainly after that, if there's a little bit of sun exposure, if you're wearing a V-neck or rounded top and some sun gets to that area, that's less of a concern, but just try to do a bit of sunscreen, keep that area covered.
Can I ask a question?
Hi, Melinda. Yep.
Yeah. All right. I'm starting radiation in about 3 weeks, and I had my meeting today actually, and I think I'm having 5 weeks of radiation. I'm just wondering, because the talk you said it's not usually that long.
Yep. So certainly 5 weeks is still one of the standard courses that we do. The reason that we might choose a 5-week course would be if we're treating the chest wall and the lymph node areas as well. Yeah. And sometimes based on your anatomy and when we get to planning, sometimes the actual way that the radiation dose is distributed might look a bit better with doing that 5-week course and just gentling the dose out a little bit more. So it's certainly still a standard treatment, and I still use that course commonly if I'm concerned about there being any extra little hotspots or treating the lymph node areas.
Can I just take one other question?
Sure.
I'm just wondering why you don't use a henna tattoo so it's not permanent.
It's a good question. I know henna can certainly last up to sort of 6 weeks or so, but I guess there's always a risk that it could rub off. And if that were to happen, we'd have to go back through that whole simulation process. And as much as we can, we want to limit both from a logistics time point for you, but also extra radiation dose with a CT scan if need be. Yeah, there's lots of thoughts around that, and looking at things like the tattooist radiation or using markers or stickers, but there's we need something that's definitely reproducible and, you know, can be relied upon for possibly between the time you have simulation and then 5 to 6 weeks of treatment, 2 months in total sometimes.
Yeah. Okay, thank you.
No worries.
Melinda, have you seen them? They're very, very tiny, so don't worry. They're a tattoo of the planet Earth from a distance is the best thing someone ever told me.
Thank you.
A little pinprick.
Yeah. Maureen, did you have a question there? You might need to unmute if you just press the bottom left corner.
Yes, I just want to ask, can radiotherapy, if you've had lymph nodes removed, the axillary clearance, can that trigger the actual lymphedema?
It can do. It can be sort of a combined effect of both the surgery plus the radiation together. The radiation itself can be delivered to cover the axilla or the armpit again, or it can just be over the collarbone area and the upper armpit. And so those slight variations can mean a slightly different risk of developing lymphedema. If you've had both all the lymph nodes removed in the axilla, so a clearance, plus radiation to that area, fortunately that puts you into sort of the highest risk category, around that 30% chance of developing lymphedema, whereas with surgery on its own, it would be about 15% to 20%.
And the other question I just had in regard to triple negative breast cancer, when you're saying like the radiotherapy reduces the risk of reoccurrence by 2/3, is that the same for people who have got a higher risk of reoccurrence, like with triple negative breast cancer?
Yep, so that risk reduction is talking about the reduction locally, so in the breast or the lymph nodes, and that's a number that sort of applies across the board for all types of breast cancer. Certainly with triple negative, there's a slightly higher risk of what we say systemic spread or spread outside. And that's why usually you'd have had chemotherapy, which is the sort of mainstay of treatment to reduce that risk.
Yeah, but just from the point of view, it is like 2/3 the same as anyone else, is it?
Yep, that's right.
Yeah. Okay, thank you.
Can't see any other.
I have a question. When you do radiation therapy, what sort of bra should you wear? Is it like a bralette or, you know, no underwire?
Yep. So
just want to get prepared.
Yeah, absolutely. So usually we say to avoid underwire. One of the areas that can be a bit sore with radiation is the under the breast fold, and that can be because the skin rubs in that area and it can peel away a little bit. Yep. So having underwire there might irritate that a bit further. So a soft cotton bralette's fine, but just to avoid the underwire.
Thank you.
I've got a question.
Yeah.
It's not relevant for my current situation, but how do women, can you like breastfeed after radiation to that breast?
Yep, you can. They've looked at women who've had breast radiotherapy. The volumes of breast milk that they can produce can be lower, and some women can't. And obviously, if you've had mastectomy, you can't, but you can still. There is still a chance of being able to breastfeed after radiotherapy, but it just might mean it might not be guaranteed, and your milk volume might be a little bit lower.
it's not like it doesn't make the risk of whatever comes out of that breast any
No.
more
So
toxic.
that's not harmful at all.
Radioactive
So
milk.
no, good question. So not harmful at all to the baby. You wouldn't be able to breastfeed during treatment or in the
Yeah, of
months
course.
afterwards, just because it would be
Yeah,
painful and be a bit of inflammation. But years down the track, if you were to fall pregnant and want to breastfeed, your breast would still likely go through those changes that would come with all the hormone changes. So with radiation, even though there's no actual radiation that's left in you, you're not radioactive in any way. The only radiation that's there is when you're glowing in the dark and no superpowers. So the radiation is only there when the machine is on, the beam is on, and that's for about 2 or 3 minutes really. And that's the x-rays coming out of the machine. Once that's off, there's no radiation left in the room, there's no radiation left on you, and you'll see our staff are coming in and out of the room at certain time points, so that there's only a couple of minutes when you're there by yourself that the radiation's actually on. The radiation effect continues to work because that DNA damage has happened, and then as those cancer cells try to cycle and go through their repopulation cycles, they then might die off down the track, but there's no actual radiation that's still within you.
You must get so sick of Gina of people saying, am I going to glow in the dark?
Not at all. I like the fun questions about radiation.
And that's a good point about breastfeeding, isn't it? Like, there's different people in different situations.
Absolutely.
In life. I never thought of that before. That was
yeah, and we do see a lot of women who are in their sort of childbearing years that do get breast cancer, or breast cancer even associated with pregnancy and breastfeeding, and so they're very important considerations for us to work through with patients about fertility preservation and breastfeeding and breast conservation and all those things, because they can be very important depending on what life stage you're at, obviously.
Yeah.
I was just going to ask, I've had ladies say to me that they haven't had mammograms because they're worried about the effect of the radiation from the mammograms. Now, I've been told that it's minimal, the radiation from them.
Yeah, you're asking the wrong person, because the dose from a mammogram is about it's a minuscule dose compared to what we actually deliver therapeutically. Certainly we know with CT scans, with any x-ray you have, there's radiation being delivered. It's a very tiny dose. The risk would be minimal, and it's all risk benefit. So the risk of that tiny dose from your mammogram certainly doesn't outweigh the benefit of detecting an early breast cancer. And we know the statistics of 1 in 8 women at risk of that. So overall, the risk benefit just doesn't weigh up. But we always are, and we never want to over-investigate or overuse CT scans or x-rays. And so even still, I joke about it that the dose is low, but we still wouldn't just send you off for mammograms every 3 months or do a CT scan just to check for the sake of it, because it still is radiation dose. And in medicine, we want to make sure that whatever we're doing has got a good, risk benefit profile. But I would certainly say to those women that, the risk would outweigh the benefit of that small dose of exposure. With the technologies that they use in radiology departments, the quality of the mammograms for the dose that they now need to deliver is so much better as well. And ultrasound's also another alternative that we would use. And for example, in sort of young women, let's say a woman's had their mother's developed breast cancer at 45, and you want to start screening them earlier at 35. In those women, you might use ultrasound as screening. And ultrasound versus mammogram versus MRI have different benefits and pros and cons depending on your age, the type of breast tissue that you have, whether it's very fatty or glandular tissue. So it's there are different options as well as to how to screen, but as a standard, what we would recommend is still the standard of mammogram for women.
What about women that are only 40 that start to have them? Would you recommend them have ultrasounds rather than mammograms?
Depends a little bit on what their breast tissue is like. If they've got very dense glandular breast tissue, then sometimes you need actually both studies to get a good picture of what's going on. And again, it would be, what is the indication as to why they're having it from 40 onwards? Is there a strong family history and that? But I would probably recommend mammogram still in that case.
Mm.
So I put in the chat, Gina's going to send through to Kristen and I the actual slideshow. So we'll be able to send that out to everybody. So just in case you missed anything or you wanted to look up some of those links, you'll get the slideshow, which will have it, which is great. And we are recording this with Gina's permission so that we've got it on record. We need to check back on anything.
Yeah, and I think some of those good, Gina, how you added those questions that have been submitted, and like you said, there was a few questions. I know Mandy's online tonight. She asked all those questions. I think she's still on about the heart. So there were some good questions, and I think you addressed all them about risk to other organs, which I think was and you addressed long-term issues, long-term side effects. So I think we covered that. So yeah, does anyone else have anything that wasn't covered that you asked or want to know?
Well, feel free as well, if something pops up in your head, to email. Kristen's got my details, so you can send through any questions. I'm happy to email back. And
cool.
Sorry,
you're saying something?
Sorry, I just did think of something. It's Melinda again. Is it standard, not standard, to put any sort of covering on your skin normally to protect it during the treatment?
I think Gina's frozen.
Oh.
I think
Gina, are you still there?
I think she's frozen.
Do you mean when you say cover on skin, do you mean cream, or you talking? Did you see the pictures of the bolus or that?
No, I think someone told me that my friend had it and that they put some sort of blab wrap or something over her skin.
Yep, back in the presentation that she did, there was a thing. There was mesocel, or I think it's called.
Mesocel.
And there's another couple of different ones. It's in the presentation. And they use that when you need it. So they watch how your skin's going, and depending on whether you need it. And I'm pretty sure I've heard of ladies having that at St. George. Is that right, Moira? Do you know? Thumbs up.
Kristen, it's Kim.
Yeah, you can speak.
Oh, I was going to say, I know that they use it for women that are having radiotherapy to the chest wall, because obviously it's easier to place the Mepitel over that area. It needs to be changed, I think, every week.
Yeah.
But it certainly does have benefit in protecting the skin.
Yeah, so when you say chest wall, to just clarify, that means like people who've had a mastectomy are more likely to need the film. Is that correct?
That's my understanding. Moira, do you want to add anything in?
Yeah, no, they do use it on chest wall, as Gina was saying before, to try and protect the chest wall and the ribs and everything underneath and bring the dose up to the skin.
Kim, what are you looking for down there?
Hey, Kim.
I just found a little something from dinner.
But I have seen Mepitel used on like a breast as well. But sometimes they've got to overlap the Mepitel. So and sometimes if you're quite active, it can tend to, you get a bit sweaty, and it does need to be changed more frequently than once a week.
I don't know if you want to hear my recent experience with this, but they thought they'd try Mepitel with me, but because I hadn't had a mastectomy, it literally lasted 1 day. So
oh gosh, Mel.
yeah, so if there's still a breast there, what they were saying to me was that it's hard for it to stick down, and if you have to keep replacing it so often, then that hurts the skin to keep taking it off and putting it back on. So they want it to be able to last at least a week at a time. So they might I was at St George Public Hospital, and they tried it, but it didn't work
Yeah.
out. But for other people, it might work better depending on the shape of your breast and things too.
Yeah.
They said to me. This
I
was
think
just
prob-
recently.
Sorry, I think for larger breasts it would be more difficult for Mepitel, whereas with smaller breasts it might tend to go over the smaller contour of a small breast and stay on easier. Yeah.
Yeah, that's what they said to me too.
Yeah, that makes sense.
Hi, Gina. Welcome back.
Sorry, you dropped out and then I forgot to click it.
Oh, down there.
I just wanted to ask in regard to, I'm coming up for second year scans for triple negative. Should I be having a PET scan as well? Because of, the higher risk of reoccurrence. When you're having your 2-year scans, you're only having a mammogram and an ultrasound. What's your advice on that?
Gina, you're on. Yeah, Gina, you're on mute.
Sorry, there we go. So it's not standard to do screening scans with CT or PET. There's been no benefit shown to doing that regularly in terms of finding things earlier or helping improve treatment outcomes. So at this stage, those scans are still done based on a sort of symptomatic basis if you need. PET's only a recent thing that's come into play in the breast cancer space. It's only been there for a while with other cancers, but now rebatable, and we use it more upfront in staging. So if there's a risk of there being distant spread, or if we're looking, we do PET and or CT and bone scan.
Yes, my oncologist said some ladies are getting it done and others aren't, the PET scan. So I just didn't know whether you're supposed to wait till you have symptoms, or if you have no symptoms not to get it done, or...
Yeah, it's not routinely recommended, and some people do have a personal preference to do so, but then that comes, I guess, with the risk of one, like the radiation exposure, so doing, and two, if there are things that are found on the PET scan, it can lead to false positives, extra investigations with needing extra biopsies, and and extra stress and anxiety and complications associated with that. So there's that side to consider.
Yes, okay, thank you.
Gina, can I just ask you something? It's Diane here. I had cancer again, breast cancer again last year and previously 12 years ago. And I noticed that this time they had a mold of my body to put onto the bed to keep me still. Not that I'm a fidget, but I know a lot of people are. Is that a normal thing now that they're doing, so that you sort of fit into that groove, and it's much easier if you've got to have, fairly lengthy time?
Yeah, so there's different ways, I guess, we position and try to get people in a still and stable position. What you're describing sounds like what we call a vac bag. So it's essentially like a bean bag that you lie on, and we squeeze it up around your body and then suck the air out of, so it molds to your shape. And we certainly do use that. It depends really on different departments have different protocols. Some other departments use what's called a breastboard, and that's a board that we can angle up and have your arms resting, and we put it in sort of different, you can record what angulation things are at. And it sometimes does depend on the department, to your body shape and size, and how much stability you need. So, and how much reproducibility you need. So it's not...
Well, kept me contained on the bed. I might have sort of flopped over otherwise.
Yeah, and also sometimes just if you're having more areas treated, you need to be stable for longer.
Yeah.
So there's a few different reasons. One's not necessarily more superior than the other. There's just different indications for it.
Good, thank you. It was just interesting that 12 years ago I didn't have it, but this time it did not. It worked. It was good.
Good, excellent.
Yeah, and that both of times was at St George, wasn't it?
Yeah, yeah. And I'm never doing this again without candlelight. I can tell you that right now. my God, seeing yourself, oh, this is not good, girls. Not. I'm going to look
Without
into that
what?
list
Candlelight?
next year early.
No, wearing masks are the worst because all you can see are wrinkles about where the eyes are. So when the body you can see.
Advantage of Zoom, we don't have to wear masks.
Exactly.
No.
Yeah,
Is Halloween on a Wednesday night?
the Saturday night.
I don't know, there might be lots of people dressed up as something with masks, won't there?
Cool. Not good.
Are there any other questions for Gina? Because I think time's getting on and we might have to let it go.
Let Gina go.
Yeah.
Right. All good. My son's been put to sleep by my husband, so I've got all the time in the world. All good.
So we'll say thank you, thank you, Mr. Hesselburg, for his help for giving us your time today. We would certainly appreciate. I know it's a precious gift of time, and we really, really, really appreciate it.
All good.
Oh, it was so good.
Yeah,
Thank you
thanks,
so
Gina.
much.
Very interesting.
Okay. Thank you very much.
Okay, we'll let Gina go then.
No worries. And shoot through any questions you think of, and I'll share the slides too.
Excellent. I'll copy out the
Thank
links
you.
and make them easy so that people can click on them and all that stuff. Thank you.
Thanks for coordinating.
Good night, Jenny.
Bye.
Thanks,
Gina.
Bye.
Good night.
Bye.
See you all. Bye. Good luck with all your treatments.
Cool.
That was great.
That was fantastic.
Very good.
Aren't we lucky? I mean, having 3 professionals. And so lovely to see you, Kim and Moira. Thank you. Oh, no, it's been
Thank
working.
you.
Hey, you did it.
It has been good.
Yeah, Moira's here.
Hello.
Hello.
You want to talk about Ewan for next month?
Yep. So next month on the first Wednesday of the month, we'll have he's doctor, isn't he? Dr. Ewan.
Yeah,
on
associate professor,
pathology. So do you want to give it?
Associate Professor.
Yeah.
Do you want to talk about it?
Yeah, he's
We
going to
had
talk
him
about.
before.
You have. He's.
Yes,
Oh,
we
yeah,
have.
I think it was
fantastic.
last year. Was it last year, girls, or was it the year
He's
before?
really good. He's
Yeah.
really good.
So
He does the dissecting.
correct.
Yes, that was interesting.
Yeah. So he
It's the pathologist, is that right?
correct.
Yep.
Yeah. I've
Yeah.
been waiting for
Yeah,
that
he
one.
jumped at it, didn't he, Moira? When you asked him.
Oh,
It's funny.
fabulous.
We
We were
called
only
it.
talking.
Yeah, go on.
Yes, we did. He was at the cafe, and as Moira and I were leaving, and there he was, and we went, "Beauty, you're there. We're asking you."
Grab him quick, girls. Grab him
We
quick.
did.
No, he was very happy to offer his time and to come and speak in a month's time. So, yep, tune in. Same.
Yeah, that was good.
Yep, same.
Yep.
Well,
So-
girls, I might have to go because
Yep, I think
Kim
we'll
might
all
have to
end
go.
up.
We've got
Yes.
busy days tomorrow. Kim doesn't know it yet, but we've got busy day tomorrow.
Now I do.
So
Yeah.
have a great month, ladies, and celebrate.
Yep.
That
Pick
that we're all able
Nice.
to meet and support each other.
Yeah. Thank
Thank
you.
you.
Thank you, Moira and Kim.
All
Thanks,
right.
lovely to see you.
Yep.
Thanks so
Nice
much.
to see you,
See you,
all you
girls.
guys
To see
too.
everyone.
Yeah.
And just a reminder,
Bye.
Camellia Gardens morning tea is on the 17th. What time, Glenda?
9:30.
9:30, Camellia Gardens up in Carring Bar. There's a table booked if anyone wants to go out in public and have a cup of tea and have a chat. That's an opportunity. Other than that, we'll have I suppose, casual Zoom on the third Wednesday of this month. And then on the first Wednesday of next month, we'll have the official one with Dr. Ewan, which is last time he was very technical and some scary photos. So just be prepared in case he shows tissue, stuff like that.
But very, very informative.
But yes, you don't realise how important pathology is until someone really explains all that.
That was amazing, that talk. It was
Yeah.
very, very interesting.
Yeah.
How they dissect everything.
Yeah. So again, we'll email out the
the PowerPoint presentation to everyone so that you've got it.
So I couldn't see any of the photos myself.
Okay.
But that's okay.
You mustn't have clicked.
see
Yeah,
when we,
I only realised halfway through I had like gallery view, then I swapped to speaker view. So the recording, and a couple of times I had messages popping up like Alita would sign into the wrong Zoom. So I'm hoping that that screen that popped up didn't overtake the Zoom recording. So I apologise in advance, but I'm learning. So we'll see how the recording works. And I'll have to wait for her to email me the PowerPoint so that we can actually use the hyperlinks for all those things she suggested, but I'll get onto that.
Yep.
Perfect.
All right.
All right. Thank you, girls.
Hey, do you want to close up?
I'll talk to you soon.
Yep.
Terry, how you doing? No.
See ya.
Bye, everyone.
I couldn't hear you, Diane.
It was all right, darling. I was just asking how Terry was because I haven't spoken to her for ages. So I just wanted to see how she was doing.
Is Kerry that's still on?
Yeah, yeah.
She has to unmute. Kerry, you have to unmute. If you can find out where.
No, she's frozen.
All right, sweetheart. It was just me asking how you're doing, love. I haven't seen you for a while.
No,
you
Yay, I'm here.
Oh, no. Excellent, excellent. How are you?
Well, look, if a grief counsellor were to ask me all the questions, are you sleeping? Are you eating? Are you exercising? Are you maintaining your social contacts? Are you engaging activities that are fun and satisfying? Are you planning things that give you something to look forward to? Yes, all of the above. But I'm still missing 24.
Oh, darling, that's never going to stop. It's never going to stop. But that's okay. So just take care.
Yep.
Yeah,
Okay.
I can see Diane doesn't get the benefit of seeing, but I get to see Kerry on Facebook. She's been traveling, she's been flying, and she's been socializing with people. She's been very busy. And then, you know, you'll see a lovely memories sharing of Tom and
beautiful,
lots of nice things, which is also it's nice to see friends around her who also miss Tom as well. And you know, I saw her post the sad wall. That was very sweet. So it's nice to know from, you know, like Di would appreciate to know Kerry is working hard at like you said, keeping social, trying to keep in touch with people, keeping herself active and outdoors. So she's doing all what she's meant to do, but like you said, it will never ever, you know, you'll never ever.
No. As I said, the whole the edges of the hole just soften, darling. That's about all you can, you know, expect to happen.
And I remember, Di, I think you told me something lovely once. You were talking about grief, how sometimes it's big, sometimes it's small, sometimes it's big, and it changes every day.
All the time, all the time.
It doesn't shrink, it just flexible.
Yes,
I thought
exactly.
That was a good analogy.
Yeah. Yeah. Well, you take care, Kerry.
Thanks.
No worries, darling.
And did you have a nice trip down to Canberra?
Oh, yes. We had a wonderful time. We did, I think, about 10 op shops. Also, I go with a very op shop people. So we gave Vinnie's and Sally's a real good workout.
Wow, I stopped in one on the way home today. Bought $30 worth of stuff.
Oh, really? Yeah. Oh, life isn't complete without at least one visit a week.
Exactly. It's good for the environment. We should recycle more.
Exactly. I only do it for that. You know, helping the economy, all that sort of stuff. Yep. All of the above. Right. Well, take care, sweetheart.
Okay.
Good to see you, Anita. Bye, darling.
You too, guys. Sorry I had trouble getting on.
Yeah.
Just glad I saw the message pop up that you're on the other one.
Oh, I can never find the right link.
I'm sure there are probably lots of other people the same thing, but I'm just so glad that I was able to see it because there were so many things happening on and things beeple and people joining in and Glenda kept dropping out and then this other Glenda dropping out, signing back in, and Maria was having trouble and she was calling me and I had things going on everywhere.
I don't know how you do it. I'm
You did
having trouble
well.
just sitting here looking at myself. This is just beyond my comprehension. Oh my God.
This is new to die. This is new.
This is scary. That's what it is.
Is this your Virgin Zoom call?
Yes, it is. It is. Yeah, and my last.
No, it's not.
Can you tell that I've had practice? I've got makeup on, makeshift foundation, lots under the eyes, and front face lighting.
Oh, I've got makeup on. It's just the overhead lights don't do a thing for me. Right, next time, definitely candles.
Soft front light.
Exactly. It's exactly
Oh,
right. Whatever Anita's doing is good. I like that. Soft focus, wonderful.
Yeah, and it's got to be from the front, otherwise it makes the bags under your eyes even worse.
My hair's white, but it's a lot whiter.
Yes, it looks very white, but I know you were trying to ease toward the white last time I saw you, probably.
Yeah, well, it's white now. And actually, I think it's whiter from shock. I mean,
it looks lovely. It looks lovely.
Darling, thank you.
It's a lovely colour white. It's really
simple. Thank you. Well, I waited long enough. I had mousy brown hair for all of my life, pretty well. So it's got to be some benefit at some end of this. Yeah. So anyway, that's good. And I'm getting that facelift soon. You girls can have this Zoom stuff. I'm not sure that I'm cut out for it.
Yes, you are.
I tell you what, it's even worse if you do it on your phone, and when people like hold their phone like that and then it's looking up their nose.
Oh. I can tell you some dudes, like it was enough watching kids trying to search for boobs. I think it's helpful you move the screen so that we can look at your face, not your boob, and then look at it going down in your...
And then, but Moira at the same time was trying to explain about the Cetaphil stuff on a chest wall, and she's fiddling with the boob too.
Try doing that in a serious meeting. That's, yeah, and that's when you use the chat, and you like I do it often with my boss. I'll do instead of doing it to everyone, I'll do a separate. I'll just show Di so you could do it. See, I can pinpoint, these are all the people that are on screen now. Yep. So I could send a leader a message that only she will get. So I do that with Ben. I'll send him a message about something, then all of a sudden he does a big smile because he's just... You've got to be so careful though.
So you don't want to get that wrong. That's the wrong person.
Some people were typing over the screen.
I have done that. I've actually then clicked on and sent something to everybody, forgetting that I've done that, and sent a comment about somebody and, oh no, it's got... Nice though.
Do those all disappear?
I don't think I can do this.
Hello, Monty.
Well, it was good to see you all anyway. Yeah. We miss our Wednesday nights, don't we?
Yes.
One of
Have
you,
another get together.
Kristen,
yeah,
one of your doctors was on TV last Sunday, or one of the George doctors. I can't remember who it was.
I wonder if it was Dr. Fadke about his retiring.
No, it was a lady.
Oh.
Lady. Oh, so where do you, can you remember where was it on news?
It was on the news, but she was down a corridor somewhere.
Yeah.
Yeah.
I've seen so many doctors lately in the news talking about more about some COVID stuff, about, wear your mask and stuff like that. It's hard, apart from Dr. Fadke, I can't remember. But yeah, unless you can remember, if you can remember if it was on like Channel 7, Channel 9 news or anything like that, I can often look it up and find it online. Like sometimes people bring up something at support group saying, oh, did you see the last thing? And most stuff's online, but unless you can remember, the name or what hospital or what channel you news you saw it on, otherwise I can't find it.
Okay.
Okay.
I know it was St George Hospital, and it was a lady.
Okay.
I know there are a lot of lady doctors there.
Well, we might end up, if that's okay.
Yep. I need to cook dinner.
Oh,
Anna else just made us a cuppa, so yeah. We're going to have a cuppa.
Oh, time for a cup of tea.
Well, it's Narelle's birthday today too, so we had dinner last night. Yeah, 21 again by 3 times.
3 times. 3 times 21.
I bought the cake last night. We were all, there was 20 something of us went out for tea last night, and I went and bought the cake at Michelle's Patisserie, and they were doing a filming. Anyway, one of the guys that was involved in I asked them if they just moved out of the way so I could have a look at the cakes. And he said, oh, you know, this Black Forest cake is fantastic. It's the best one. I went, no. They have that at her work every time. No, don't do that. And he said, I said something about being my sister. And he said, oh, well, you know, these two here are really good for older people.
Oh no!
I gave him a filthy look and said, I wouldn't even go there, mate. That was really, really cruel. So
It's like the hot water man that said they didn't want the old ladies to go without the hot water tank when you lost your hot water tank.
How rude.
No idea.
Well, we are grateful we are mature. Like
That's right. Not to the stage of rotting.
No,
That's right. Not everyone gets the privilege of being able to be mature. So we have to look at it that way and say, aren't we lucky we're old?
Good way of doing it. Yes.
All right.
Okay.
Good to see you, girls.
See you, ladies.
Bye.
See ya.
Bye.
So
Bye.
stop recording and bye.